I'm Jerry Canoka. I'm the Executive Director of Network, and we do things to try to help students engage more so with the area business. And so today, we're at Indianapolis EMS's headquarters here in Indianapolis, and we're going to talk about emergency healthcare careers and roles. These great professionals are going to be sharing their experiences and telling you what their days are like, and they'll be taking your questions. So as they're saying things, be thinking about what you want to ask. And so right now, we're going to start with Michelle. Each one of them are going to tell us a little bit about who they are, what they do, what brought them here. And so, Michelle, why don't you go ahead?
Morning, everybody. My name's Michelle. I'm an EMT here with EMS. I provide basic life support to people in this community. I got into this because I rolled up onto an accident where an elderly woman hit a bicyclist. I stood there and I was like, 911, hello? And I didn't like the feeling of not knowing what to do, so that's what got me into this. JP?
Yeah, my name's John Paul. I got into this 9+ years ago. Similar situation to what you guys are in. Did it through a high school career center with the goal of getting further into emergency medicine. So started off as an EMT, worked as an EMT for a long time just because I like to drag my feet. And recently went through paramedic school and am a fairly new paramedic. Stephanie.
Hi, I'm Stephanie. I'm a paramedic educator here at Indianapolis EMS. I've been in EMS for about 11 years and a paramedic for about 6 years. When I was a paramedic, I was an FTO, which means that I take care of the new hires and teach them how to, run the ambulance on a daily life. I was also a preceptor, so any of the paramedic students that would come through, I would teach them how to run the ambulance. And that really got me into teaching, so I became a paramedic educator a few years ago. So we have a video for you guys. We're going to show you just a little bit of piece of what we do on our daily life.
Monitor on there?
Yeah.
Have everything. Like all the IV stuff looks good. Check the airway cabinet. Make sure our intubation kit's solid.
Alright. Detected it.
Check pads.
Good deal.
Like we got enough albuterol to last us for the day.
Looks like we got all our meds, EKG strips. IV supplies look good.
Yep, we got plenty of tourniquets. Do we need any, do we need to refill the truck with any meds?
We could do some more aspirin.
Okay.
Got all of our trauma supplies.
Yep, check the glucometer real quick and I think we should be ready to go.
911, what's your emergency?
Patrol Medic 30 chose responding to the unconscious person. You know where you're going?
34th and Georgetown.
Okay. Alright, so we're here.
We used to fear flopping stuff down.
Yeah.
I love it.
Stephanie, will you see if this guy's got a pulse? I don't think he's breathing.
No pulse, no breathing. You want to start compressions? You want to get your intubation equipment ready?
Yeah.
I'll start bagging.
Some 8, 29, 30. 30.
Okay. Go ahead and try for the tube now.
All right.
Michelle, if you'll get that tube ready for me.
So what he's going to do is he's going to place a plastic tube inside of the airway so that we can get a definitive airway, and it's a lot more secure. So he's going to take the scope and he's going to lift the tongue and the epiglottis out of the way so we can get a better view. And he's going to stick the tube between the vocal cords and into the trachea. And then once he gets that, he's going to inflate the balloon that goes inside the trachea so that it secures everything inside of it so no air gets out and no fluid gets in. And then we're going to place this tube holder on him so it secures the whole tube itself so it doesn't pull out. We usually do this for patients in cardiac arrest, respiratory arrest, or just failure. Patients that are too altered to maintain their own airway.
One more squeeze.
All right, I'll get back on the chest.
Tube's good. Resume PPR.
All right, so that was just a little piece of what we do every day. We can go anywhere from somebody who just needs to have a conversation with us, a sick person, cardiac arrest, overdose, gunshots, so many different things. So now that we've shown you a little bit about us, what questions do you have?
What's your favorite part of your job?
My favorite part of the job is that every day is different. I mean, some days I might only have 4 calls, and the next day I might be running around having 12 calls, never seeing the station. So every day is different.
I like the constantly on the move, on the go environment. I have significant issues with sitting still and not moving around. So, you know, obviously you got to kind of sit with the patient when they're in the back, but otherwise, you know, when you're not in immediate patient care, you know, we have pretty significant amount of freedom to move and go wherever we please.
I'd say the same thing. Just everything is different every single day. It's never the same. Sometimes you might bring a life into this world. Sometimes some might, you know, fizzle away right in front of you, and there's not a whole lot that you can do about it, even though we try our best. And then there's all that in between. So you just never know what you're going to get.
What is like the type of medicine you use on a daily basis?
Well, that varies very much between call to call. Tender love and care is the most abundant medicine that we use, and that's on almost all the calls. But for cardiac patients, we have ACLS drugs, epinephrine, amiodarone, calcium. For pain management, we have a couple different narcotics. We can treat seizures with other drugs. I mean, we have a lot of options out here, but it's very dependent on what's wrong with the patient and what they need.
This relates to the pharmacy.
It's very involved with pharmacy. I mean, we carry usually 2 bags to every call. All those calls have a full stock of ACLS medicines, Zofran, medicines to treat seizures. We carry narcotics. You know, we roll around with our own pharmacy of both controlled and uncontrolled substances. So, yeah, we're a rolling pharmacy, and we're expected to know drug doses and know how to calculate drug doses, either on your own or with very minimal help, and know what those orders are for the specific patients, their condition, and, you know, how you're going to treat them. So, pretty pharmacy involved.
What do you do when you panic?
We just don't do that. You have to be able to put on a good show. even if you don't really know what you're doing, there's a saying called fake it till you make it. There are definitely scenarios out there that we are barely equipped to handle. I mean, we can handle a lot of things. If you're actively dying, we can manage that and most of the time reverse that. But there are definitely some things out there that are hardly in our scope of things to handle. And when you get to the emergency room, you'll have doctors that are like, I don't know what to do about this. Let's call specialty care. And so when you get into that situation where someone is messed up and sick and you're not really sure, you fall back onto your basics and go from there. And even if you keep circling back around to your ABCs and your basic general care, if it keeps someone alive, it keeps someone alive. But the last thing you want to do is show them that you don't know what you're doing and that you're panicking too, because that's going to make things ultimately worse for their already worst day.
How often does that happen? You run into things you don't expect. Is that the majority of your time, and you rely on the foundation of what you've learned, or most of the calls routine?
I think, well, we have a general understanding. We'll have notes from dispatch for our run. And then as partners, we kind of talk over, like if it's a seizure, JP will have seizure medications. If it's a working arrest, we'll know the necessary equipment to bring in. And then if we're ever like stumped on something, we have each other to bounce back ideas.
Okay.
You know, those calls where you get stumped or you feel like you want to panic, there's a thing called being a black cloud and being a white cloud. If you can stay in the gray cloud space where you are not just a crap magnet, then those calls where you panic or want to panic are, you know, fewer and further between. A lot of the calls that we run out here, especially on the ambulance, are pretty routine. Some people just don't know how to manage themselves healthcare-wise, and so you run into some chronic issues, and you know, you deal with those as they come up. But it's, you know, one exciting call, but you had to sit through, you know, 20 very run-of-the-mill, okay, you know, I'm running you to the hospital because you've got a toothache from an infected tooth or you're out of your meds. You know, you'll run 20 of those calls before you get something that really puts, you know, what we went to school for to the test. And so that's where rehearsing, like Michelle was saying, you know, either rehearsing what we're going to do on the way to the call or even in our continued training, you know, we rehearse for the worst things so that when that happens and all that pops off, we're good to go.
So the question that had come from the other class, what's something that you learned in the field that you did not learn in school?
I think something that I've gotten better at is talking to people. You can run through your basic information on a patient, get their history, their meds, their allergies, and you won't really know what's wrong with them until you start talking to them and, oh, you had a bad taco the other day, and like that's probably your reason you're sick. So talking to people and then easing their problems, that is a big thing that I'm continuously learning.
Kind of like she said, I think that's probably the biggest, because just like Stephanie, I'm an FTO, so we see a lot of the new employees and people who are fresh out of EMT or paramedic school. This is probably the biggest struggle that you'll find is these people don't know how to talk to people. And that's cool, like, you know, no one's expecting you to just go out there and be a conversationalist, but, you know, it comes with time, and sometimes you have to really learn how to suss out the information. You know, we had a guy yesterday that called for chest pains and was not leading on with any information, and, you know, it was being very patient and slowly digging away at his history and what was going on, to where we found out that he'd had chest pain a couple days ago, but what the real problem was he had been out of his medicine for a while, and he was having psychiatric issues, and it took, you know, if you went completely by the textbook, you would have thrown him on your monitor, said, yep, this guy's not having a heart attack, managed his vitals and gone to the hospital. But it's really chipping away at, okay, you know, I feel like there's something more here, you know, ask a question, read out that answer, ask more questions, and then you can hand that off to the hospital to make their job a little bit easier, but also to make sure that that patient gets the appropriate care resources.
Stephanie, from your point, how does what we're talking about apply to what you teach?
So I can teach, like JP just went through our class. I mean, I can teach you the skills. I can teach you the different calls that you're going to get and how to manage them. The thing that I can't teach you specifically is how to go in there and manage your own scene. They're different every day that you go in there. You might have a normal day where you just have to come in there and talk to the patient and ask their history and go about all that kind of stuff, but you're going to walk into these different scenes that are going to go downhill really fast, and you have people coming at you, you know, screaming, yelling, upset. You know, we have unsafe scenes, so you have people that were shot, and you have family members coming and swarming you, and you have to learn how to manage that. And I can't teach you that because I don't know what it's going to be like every single day that you go out there. You just have to fake it till you make it, like JP said, and, you know, figure out what you're going to do, manage the fire department, manage your team, manage the patients and everybody else that's there, police officers, whoever else is there, and just do it.
I've got one that has put in the chat. It's how do you, or how did you, deal with someone that was trying to hurt you?
All of us have dealt with that in some way, shape, or form within our careers, and it's just something that you have to be prepared for as much as possible. We always have to make sure our scenes are safe. Police are usually on scene if it's deemed an unsafe scene prior to our arrival. So any call that we go onto, we have to continually assess our scene and make sure that everything's safe. Even on the silly calls that are just a stubbed toe, like, you have to make sure that that scene is safe, because you never know, do they have a gun, do they have a knife, or is it a psychiatric patient that's off their meds and there to hurt you? You just really never know, because they can turn fast. So scene awareness is your best friend.
It comes along with the skill of learning to talk to people, also learning how to talk people down. We have several options when it comes to dealing with unruly patients, and none of those options are super pleasant, and it ultimately involves more paperwork on my end at the end of the day. So it's obviously something I'm not going to want to do. So if I can talk somebody down with a calm and neutral tone, reassure them that, you know, I am here to help them. And some people, you know, usually especially psychiatric patients, if they're far beyond that, then they're beyond that, and we're going to have to use those alternate methods of controlling them for their own safety and our safety. But, you know, I learned a long time ago, especially working downtown Indianapolis, if you learn how to talk to people and you learn how to hear what they are trying to say, mirror it back to them, and do your best to make them feel like this deal worked out on their end, even if it really didn't. If they feel like they kind of won there, then people become very compliant and very easy to live with. But if you're hard-headed and you come at people with attitude, like, you know, this is my ambulance and you're going to do whatever I say, hope your partner is good at tying the restraints, because it's got to be what's going to be happening.
I'd say the good thing about working here at IEMS is that they do train us. It's called DT4 EMS. So they teach us how to de-escalate a situation and then to use some specific moves to get out of any particular information to get ourselves to safety, which is not, it does not happen everywhere that you go. Before coming to IEMS, we never had that kind of training. So to us, that's extremely helpful.
You learn all these skills. Do those have to be refreshed? Do you have to get recertified? How does that play out?
So paramedics and EMTs have their certification for 2 years, and then they have to re-up their certification. That has to do with hands-on training, different modules that you have to learn throughout those 2 years. In IEMS here, we do a lot of annual training to get you prepared for that, and just to refresh you on stuff that we don't use all the time. Like, we obviously don't have a ton of pediatric patients. We have some, but like the high call volumes of pediatric patients, it doesn't happen a lot, which is good. But we want to refresh on that a lot more. So we do that every so often, so that you're prepared for when it does happen. So we actually do quite a bit of training throughout the year, a lot more than we probably want, but it is very helpful.
And like yearly protocols change. I know for the pharmacy people, this will kind of ring true. The AHA, a lot of these associations do research and say, you know, one drug is more effective than another drug, or one drug should be given before this. And so, you know, it's annual testing on, you know, what dose are you going to give of this, or now lidocaine is preferred over amiodarone, or the other way around. And so as the climate of emergency medicine especially changes, we work through the license of a emergency physician. So as that climate changes and he finds that he wants us to perform under his license in a different way, or perform to these new standards, those are standards that we have to learn to be able to work under his license. And so it's learning about new drugs, or learning about new options for care.
Is it very costly to get your licensing, to get what you need in order to be an EMT, to be a paramedic?
It depends, I guess, on your viewpoints. To become an EMT, if you just come here or anywhere else that has an EMT program, I would say it's probably around $500 to $1,000, depending on the cost of the actual course and your books, and maybe a uniform. So it's not too bad. That's about 6 months worth of time, usually 1 to 2 times a week. And then that's pretty much it. As far as paramedic course, I would say the average is $7,000 to $9,000 with your books and possible uniforms and that kind of stuff. But depending on where you go and if you work there, they might have some sort of tuition reimbursement for you. We'll do, if you work for us after you've been here for a year, we'll pay for your program as a paramedic. And then we also have tuition reimbursement, which a lot of places will typically have some sort of tuition reimbursement. So you might have to pay up front, but you'll usually get your money back.
I know. As far as like IEMS, I know a lot of, just like healthcare across the nation, there's always a shortage of paramedics. So I know IEMS, when I went through paramedic school, I was in a special program called the Advanced Paramedic Program. So they took me off the street, and we jammed about 12 months of work into 7 months. But they paid me to go to school Monday through Friday, do all my clinicals, and basically took me out of the loop for working out on the ambulance on the street on my regular shift, and sent me to an accelerated paramedic school. We'll do that every couple of years. Right now I think we are performing like a basically like a benefits program, where if you stay on the street and you go and do the year paramedic school, and then you commit to working X amount of time afterwards, it's something around, I think, $10,000 or $15,000 that you get paid back from us, just for putting in the work of going through medic school while staying out on the street and continuing to help out there. Because I only had 6 people in my class, and even losing 6 EMTs was a hit to the operations staff. So it's, when you come to a specific program, I can only speak for IEMS because this is the place that I've worked and got most of my education through. There's definitely benefits.
You also have the difference between getting your technical certificates or your degree. So in paramedicine, you don't have to have your degree in it. You can just get your technical certificate. So that doesn't mean that means you don't have to go to college. I ended up going the college route so I can get my degree, which has helped me become an educator. So that's obviously going to cost a little bit more depending on what school that you go to, but then you have financial aid, grants, all that kind of stuff that you can use as well.
And you know, the thing that was interesting to me too as you talked is that many of these organizations will pay for you to go to school once you're an employee.
Yes, absolutely.
So I think that's a good thing to know, is that you don't always have to come up with the cash out of your own pocket. That can be part of the conversation you have with the companies, right?
Correct. Yes.
Yep.
So you're in a lot of stressful situations. You see a lot of bad things, not happy things. How do you manage your own mental health?
Personally, I manage it by having a good support group. I've got great friends that I can talk to. They're also in the healthcare field. And then I try and exercise a lot just to keep my mind off of things.
Similarly, one of my best friends is a nurse. He's worked in emergency and cardiac ICU, so I can talk to him about most anything. But more than anything else, it's going and working out either after or before work. And then I've got a dog at home, so he keeps me pretty good company. He'll listen to me complain and have nothing to say after it.
No HIPAA violations.
Yeah.
If someone wants to be an EMT, is that something that that person will stay in that role for many, many years? Or is it something they look to move to be a paramedic, to be a nurse? I mean, what does that look like?
So there's several different options once you become an EMT. We have people that are EMTs that have been here for 15 plus years, and that's just what they're happy with, and that's perfectly fine. We have a lot that already know as they're an EMT that they want to go to paramedic school. Whether they do paramedic school right away or they wait a few years to get a little bit of knowledge base on the streets, either way works. So a lot of them will become paramedics, and then sometimes they even have, greater ambitions in life. You definitely can go to nursing. There's a paramedic to RN bridge program that a lot of places offer, like Ivy Tech or IUPUI. And then you have PA option, NP option, and we have actually several past employees that have left here to go become a doctor. So you have a lot of different things that you can do.
It's a good stair step, and it's a good place to start, because with all of those roles from nursing all the way up to being a doctor, there are some core things that you will absolutely have to learn how to do to be an EMT, and that's talking to people, learning how to manage yourself around somebody else's emergency, and kind of like separate yourself away so again you don't panic. You can put yourself in that mindset of, okay, this is their emergency, I'm here to help, but me freaking out isn't going to help. So you can start here, and even at the level of a basic, you can be very effective. And like the most things I learned about EMS was not in paramedic school. It was learning how to talk to people and learning how to treat people like people, and respect them for everything they are. And even if they're having a bad day and maybe not treating me right, learning how to not take things personally.
How much into the medications, to the drug side of things, does your team get into when you're out on calls and with patients?
I mean, we have everything from push dose medicines. So, there are some medicines that you're just going to give the whole thing of to like a regular adult. And then we have weight calculated. So take whatever the patient is, figure out what they weigh in kilograms, and then figure out what your dose is. All the way to IV drips, where you're calculating how many drops are coming out of the IV in a minute. And seeing what that's doing for the patient. Is it working? Is it not working? Do they need more? Do they need less? So it's pretty well involved. I mean, we're doing everything but giving them take-home meds.
The question that was typed into the chat is, what percentage of patients are unable or unwilling to cooperate?
It's not that many. Most people are calling 911 because they have an emergency. I'd say percentage-wise,
I would find it hard to put a percentage on it. Like she said, most people that call us, whether you would think that that would need to be seen by an ambulance or an emergency department or not, it is of their opinion that it is an emergency and that it should be handled as such. And, we have patients that are very much not in any kind of emergency state, but think they are. And so when we drive away without the lights and sirens going, because it's a safety thing, they can get a little bent out of shape, and you have to explain to them that, like, hey, I'm looking over you right now. You are fine. Your vitals look good. I'm not going to let anything bad happen to you, but it would be, incredibly irresponsible of us to, scream through the city with lights and sirens on for something that is probably, chronic or is definitely not a life threat. And so, yeah, most of the people who call, they want to go. I think the most people that we get that don't want to go are people who are with the police department. And again, they are already having a bad day because the police department is involved with their life. And then we show up with our very blue pants and shirts looking like them and very easily get confused as police officers. And so that anger kind of transitions over and they're resistant to us, and we have to backpedal and be like, hey, we're not the people that put you in handcuffs. We're not here to take you to jail or do anything like that. We are ultimately here for you.
I think what one of the good thing is those people that are being handled by the police, they're usually getting ID'd or something like that. When we come in, the good thing is that we are new to that situation. We're coming in and we're typically able to talk to them and kind of realize what's going on and talk them down versus having to do something more, which is, giving medication to them for whatever reason is not something ideal. So, our best friend is learning how to talk to people and get them to stay calm so that we can not do this forcefully and just let them come with us. So, ultimately,
say if you're good at talking to people, you can take somebody that absolutely doesn't want to go, and 80-90% of the time, if you know how to approach them again as a human and hear out what they are saying and what their concerns are. I've had people that were being held down, maybe about to get tased by the police because they were acting so. Come up, let's talk, and they'll stand up, get on the cot, and have a chill conversation with you all the way to the hospital. I get a very significant amount of satisfaction by being able to turn somebody around in that fashion, because I think it would just be miserable to have to get sedated in the back of an ambulance or tied down and then have to have the same treatment in the ER when it's like there's options here, and that is, let's talk to each other and let's come to a neutral agreement that we are here to get you help, and that's ultimately what you want. And yeah, it works perfectly. And some people, you're not going to get that, but those are people who are usually pretty far gone anyways, and it's almost going to be no question, you're going to have to do a little bit extra with those people.
And to elaborate on what Stephanie said about someone, the police IDing somebody, that means they're under an immediate detention. They're not in the right mindset to take care of themselves. They're not acting appropriately like they should be, and they have a medical issue that needs to be addressed, but they're not willing to go themselves. That's why the police gets involved with us.
How realistic are those mannequins that you work with in terms of practicing procedures? Even like on the demo you did, how realistic are those?
The companies that make those have the best intentions to make them as realistic as possible, and probably all the IV mannequins that I had in medic school had been poked in probably by 4, 5, 6 classes before me, And so it was like there was no mystery about, oh, is this event? No, that was definitely somewhere where somebody got NIV. The mannequins are harder to intubate than people. People are a little bit more pliable and easier to intubate around. But there are definitely some things that mannequin companies, no matter how hard they try, cannot recreate. Smells, projectile things coming out of orifices, and thank God they can't recreate that, because we would have nobody to come work for us. They'd be all gone by the first class.
We also do have different types of mannequins. The one that we actually had can do a lot of things. It can blink, it has a pulse, it has a blood pressure. You can listen to lung sounds, it can cry. That one can projectile vomit at you. It's super fun. So there's different types of mannequins, and it depends on the price that you want to pay for that. That one in particular was probably an $80,000 mannequin versus some of the IV equipment is probably about $400 to $500. It really just depends on what it is, but yeah, you have a big variety of stuff. So hundreds of thousands of dollars worth of one equipment, depending on where you work, is not necessarily feasible. But we are lucky enough here to have quite a bit of the things that we need to try to make it look a little bit better.
I think that's just based off how many people we don't just train IEMS paramedics and EMTs, we train the fire department, we work with the nurses in the county hospital. I mean, our education department has a pretty significant load of people to teach and classes to do, and so it would only make sense that they have an appropriate amount, but also an appropriate quality of equipment to train these people, because these are your nurses, firefighter, paramedics, and even the police officers. We teach them how to put tourniquets on and give Narcan, and that requires a mannequin of some sort too. And so that's how we make sure everyone that has the potential to be a frontline first responder can do it in the most effective way and learn it in the most effective way.
Actually, the things you're describing lead into this question that was in the chat. How does an EMT get a job at a fire station?
It really depends. I would say fire stations, you have to be an EMT. Most places you have to be an EMT unless there's a program that's going to hire you and train you as an EMT, which we've done that from time to time. And there are some out there that will do that. So once you're an EMT, sometimes they'll hire you. Sometimes you also have to have your Fire 1 and 2 certifications before they'll hire you. So it really just depends on which department that you're talking about and what their initial requirements are versus how much time you have to train. There's also the difference between departments that have civilian EMTs and civilian medics versus firefighter EMTs and firefighter medics. So civilians are the ones that do not have the fire certification. So it really just depends where you're going.
My question for you guys is, what was one of the most rewarding experiences that you've had as an EMT or a medic?
I think mine in particular was having a baby be born right in front of me. She's one of those people that you never really think is a real story. She had no idea that she was pregnant. Started having abdominal pain, and we walk in to birth the healthy baby girl. Unfortunately, this mama was a little bit into drugs, so there were some things that we had to do for baby to try to manage it, but ultimately baby was healthy and hopefully is having a good life. So to me, it's always bringing the life into this world.
Similarly, it was before I was a paramedic, but it was a similar story to what Stephanie's was. We got called for a childbirth, and this lady knew that she was pregnant, but she knew like 2 days before that she was pregnant, and she was somewhere around like 27 weeks pregnant. And when we get there, we're kind of like, the fire engine got there maybe about 2 minutes before us, and can hear them inside very loudly yelling, get the medic up here now. And so I'm like, hey, I'm just going to go in there and see what's going on. And turned the corner. It was a very dimly lit house on the east side of Indianapolis, and this woman had the wrong end of the baby sticking out. And so we had to deal with that, and she did end up delivering, and the baby came out in the worst shape that a baby can come out. You know, you've heard of meconium staining. There's a lot of that. Mom was also heavy into drug use. You know, the night of her birth, she was abusing drugs. And so the baby came out very sick, and we had to work her as a cardiac arrest all the way to Riley. And, you know, to be completely honest, as we were, you know, coming into the hospital, I was thinking, you know, man, if this baby is gone, you know, I think I'm probably just going to go home for the rest of the night, because I don't think I want to work anymore after this. And we did something to switch, and I saw her face, and it had pinked up quite a lot. And she had a heart rate, and Riley put a tube in her and sent her up to the NICU and said, hey, you know, good job, she's alive. And then a month later, we got an email to follow up. We have awesome docs that work with us that will follow up on these critical patients. And he said, hey, I just want to let you know that baby that you brought in, she is, you know, doing great. She had maybe a little bit of deficits, but being born at 27 weeks, nothing that's not to be expected, and she is probably going to live a very healthy life. And, you know, she's in foster care now, but they placed her with a very good family that's specially equipped to handle patients or babies with needs like that. And so it felt great.
I've only been doing this for a little less than a year, so I haven't been fortunate enough to deliver a baby. That's definitely something I'm looking forward to, a nice, happy, healthy baby. But being an EMT, I can't give as many medicines as a medic can. So anytime I have a patient in the back of the truck and I can at least make them laugh or calm down a little bit on the way to the hospital, that's the most rewarding thing.
She's also my, like, key Spanish translator, so anytime we have somebody that speaks Spanish, you know, it could be just two people that have no idea what you're saying, and we're trying to fumble through an app. And that can very clearly and very rapidly become frustrating, visibly frustrating for the patient. And then I'll be like, all right, Michelle, start talking to this person, and she'll just break right into it. And, you know, you can see, like, immediate relief that they're like, okay, thank God there's actually somebody here that I can talk to. And, you know, again, even if it's one of those not super acute emergency things, you know, if the person on 911 couldn't tell you that you're going to be fine, and then the first two people who get there can't really talk to you outside of, you know, a phone translation app, you know, that's a whole ride to the hospital where you kind of have to hang and wait, you know, for the news on, is this something serious or am I going to be okay? And so, you know, even if Michelle doesn't know, she can be like, hey, they're concerned about this. And I'd be like, yeah, no, that's not a huge deal, you know, easily fixed. And she can relay that back to them, and they can be immediately relieved. So she's very helpful to me. I would be probably stuck on some call still if I didn't have her.
In closing, you know, from our panel, is there anything that you would have to share, you know, just briefly share with the classes? Michelle, how about we start with you?
I know that you guys are all in different backgrounds, CNA, EMT, and farm tech. But take your time figuring out what you want to do a little bit of everything. Don't think you necessarily need to rush right into 911 being on the streets. Take your time with it.
I think probably similar to what Michelle said. You know, don't get in a rush. We have people that will, the week after they've finished their EMT certification, be in line and, you know, signing up for paramedic school. And while that doesn't, it's not that that doesn't happen, and not that there haven't been some great paramedics that come out of that, we see a lot of people that struggle through paramedic school because they haven't learned, you know, anything from super basic things like how to talk to a patient and how to effectively, you know, seek out the information that you need to get from the patient, to, you know, maybe run-of-the-mill to emergency things that as an EMT I got to see, and in the nicest way possible, it was not my problem. There was a paramedic there that ultimately was in charge of everything else, and so that gave me the ability to be comfortable enough to learn things and at the same time not feel super responsible for the outcome or for what needed to be done. And then, yeah, so take your time, you know, whatever field you choose. You know, CNAs don't rush into going and being an RN, you know, learn your patient stuff like that. Ultimately, when it comes to healthcare, it starts with some very basic things, and learning how to talk to people is one of them, a huge one of them. And if you're going to be an EMS, comfortable footwear.
Stephanie, how about you?
I think the biggest thing for me is to just realize that this job will help you be able to talk to people. It'll have you learn how to deal with things quickly, and you just really don't get this kind of knowledge base anywhere else to get you into the places that you want to go, like paramedic, pharmacology maybe, nursing, doctor, PA, NP, whatever you want to do. This is a really good foundation for the things that you're going to use in the future.
This is a great team for us to learn from. It's one of those things, you may not know this, but Indianapolis EMS is the largest provider of pre-hospital care in the state. They've got, I just got some notes here, they responded to over 100,000 911 calls every year. They're part of Eskenazi, and they've actually got more than 300 EMTs, paramedics, and staff that help make all these things work. So if you've seen an ambulance, more than likely it's from Indianapolis EMS. And heck, if you go to ball games, if you go to events here in town, they're often the ones that are staffed to provide medical care there as a safety precaution. So you guys had a lot of great questions. We appreciate your asking those and sharing with those. If you have questions, you can funnel them through your teacher, but we could give you answers on things, or it could be on how do I get started in a career here, how do I do this, how do I do that. Just pass it through, or if there's certain topics, certain careers that you're interested in hearing about, Network is all designed and set up to help students get exposed to things and be more aware. So thanks for your participation, and hopefully we'll see you again soon.